of the digestive system and another installment of the advanced anatomy and physiology going on to applied anatomy for the medical professional. Now I'm going to be using the subtitles as transcribed through PowerPoint slides. So some of the language may be a little off or the spelling may not be quite right. The topics for today's lecture includes the anatomy and the physiology of the pancreas, gallbladder, and colon. First of all, the stomach is reflected back in this picture. And an incision's been made in the greater curvature of the stomach to lift up the stomach. And of course, it's attached down here by this greater omentum. So this incision's been made, the stomach's been reflected back, and now it's showing the pancreas, shown in green. Not actually its real color, but showing in this depiction of green. And then located underside of the liver is the gallbladder. Fats or lipids are not digested until they pass beyond the stomach. And within this section, the pancreas excretes through the exocrine system, pancreatic lipase, and then also bile coming from this bile duct is needed for lipid breakdown. So this shows the exocrine ducts of the pancreas, and of course the biliary duct coming down from the liver and gallbladder. So what is the name of that first segment of the small bowel, where the catabolism of lipids begins? Is that the duodenum, ileum, or jejunum? The answer is it's the duodenum. So lipids start their breakdown in the duodenum, and their absorption begins in the jejunum and ileum. Two things are needed for this process for lipids. Bile coming from the liver, stored in the gallbladder. It creates this emulsification. Instead of having one big, large droplet of oil, it breaks it down into all these smaller droplets. And pancreatic lipase, excreted by the pancreas, reduces all these lipids to free fatty acids and glycerol. And then all these tiny particles get absorbed through the intestinal lining and into this lacteal system, which is part of the lymphatic system. So there's your review. Now is medical scenario. You've got this 35-year-old man who's had heavy alcohol abuse, and he's developed a pancreas burnout where he's got significant weight loss, can't absorb lipids, and he's also developed diabetes. So weight loss is coming from the malabsorption of protein, lipids, and carbohydrates, all the macronutrients. Without a good working pancreas, you're not producing protease, lipase, or amylase. And with the loss of lipid absorption, you develop what's called steatorrhea, where the lipids just come through and it's oily in the toilet bowl. And diabetes, actually would be considered type 1 diabetes because the pancreas quits or loses its ability to make insulin because it's lost its beta cells. Okay, now onto the gallbladder. the function and diseases. Okay, here's a cartoon. Rapid pulse, sweating, shallow breathing. According to the computer, you've got gallstones. Medical scenario would be a person presenting with right upper quadrant pain after eating, especially fried foods. The patient is diagnosed with cholelithiasis. Sorry about the spelling. This is gallstones. The other name is gallstones. So the planned surgery is a removal of the gallbladder. And the medical term for that is a cholecystectomy. So next question, will bile still be produced after removal of the gallbladder? Yes or no? The answer is yes. So the gallbladder is simply storing bile. Bile itself is produced by the liver. And the way to remember gallbladder, it's just bladder is a storage site. So the other bladder stores urine, a urinary bladder. And this is a good depiction showing the stomach, the chyme from the acid and the stomach contents. And of course, in the duodenum is where all the intestinal juices begin to break down protein, lipids, and more carbohydrate breakdown. And the bile is being produced by the liver. Gallbladder is just a storage area. So people that are a much higher risk for developing gallstones are females. Pregnancy can develop gallstones, hormone treatments, birth control pills, age, people that are overweight, that have more cholesterol, gallbladder doesn't empty as well, so stones can form there. People that have a dramatically fast weight loss, and those are the people that have had gastric bypass surgery, are very high risk for having gallbladder disease and gallstones. And of course, diabetes increases the level of fatty acids, and the cholesterol lowering drugs can cause increased risk for gallstones. And this is just an interesting picture of all the different gallstones. It honestly doesn't look like this in reality. Okay, so a medical scenario. A gallbladder has been removed. Unfortunately, several stones were unable to be retrieved during the removal of the gallbladder. This is very common, that gallstones will be in the biliary tree. And instead of the surgeon trying to retrieve stones from the surgery, they'll send patients to the endoscopist for retrieval through an endoscopy. We'll talk about that later. At any rate, so several stones are left behind in this biliary tree. And the patient presents with abdominal pain, jaundice, which is this yellowing of the subconjunctiva, and it's also they'll get yellowing of the skin. So the stone is blocking bile excretion, causing the buildup of bile, and then that creates the jaundice. What type of inflammation is causing the abdominal pain? Is it hepatitis, pancreatitis, or gastritis? Remember itis, I-T-I-S, refers to inflammation. The answer is pancreatitis. And this is an example of gallstone pancreatitis, where these gallstones get stuck in this duct system. And all the exocrine fluid that's trying to come out gets backed up into the pancreas, and it causes inflammation. And this opening here into the duodenum is called the ampulla of Vater. It's not ambulance fodder, it's ampulla of Vater. Please don't look at the subtitles on this particular slide. So both the liver and pancreas share a final exocrine duct. So you see how this ductwork splits. The gallbladder is coming here. This is a cystic duct. And this duct next to it is the hepatic duct. And when they come together, they form a common bile duct. And then there's a common ductwork here as well, where it's both coming from the pancreas and coming from bile. And it's emptying into the duodenum. So this is a fun cartoon. I'm going to talk about a couple of the organs, surgeries that don't create a problem when they're removed. So organs we can live without. Here's the wisdom tooth. Here's a tonsil, appendix, and gallbladder. So I wanted to show you a picture of an appendix. This is in a low resource setting. It was done non-laparoscopically, so it's an open surgery. And this little piece that looks like a little piece of tissue is actually the appendix. And it doesn't look so bad, but it's actually appendicitis. He presented with fever, abdominal pain, and guarding is where if you touch his belly, it's very, very tender. In other options where in first world countries, for instance, with access to laparoscopy, you can avoid doing an open surgery, and without touching any of the intestinal organs, you decrease the risk of adhesions. And at least for big surgeries like a cholecystectomy, you can avoid adhesions and also improve recovery time. So patients in some cases can leave the same day. So these are the different instruments. These are Trocars, the camera, infusion of CO2 that inflates the abdominal cavity so that you can see all the organs. So this is an example of a type of surgery that would be done for, say, pelvic surgery. This is just a quick little video I took in the operating room of a gallbladder removal. And this is what the camera's looking at on the underside of the liver. This is the liver, and this bright, shiny structure here is the gallbladder. So it, in fact, is not green. I'll show you just a segment of touching these different organs. So that's the gallbladder, and it's not just lying loosely, it's kind of, in a lot of ways, kind of stuck to the gallbladder. So they need to work their way and kind of tease that gallbladder off the underside of the liver. Now, in this video, it's showing how the surgeon has made a deliberate incision in the cystic duct. Then he's going to take a cannula and inject dye and look on fluoroscopy to see if there are any stones in the duct, either in the hepatic, cystic, or common bile duct. And from that, you'll notice that there is a little bit of bile coming out when he makes that incision. So now he's going to take the cannula and he's putting it into that little incision. And now this is the fluoroscopy where you can see the cannula, and now he's going to inject dye. And when he injects the dye, you can actually see the dye flow through.
Anatomy, and I'm confident that I can put a clip on that, and that it's not a it's not one of the main ducts. Yeah, but in this case, she doesn't really have. So that may be a pancreatic duct right there as a freebie. Right there, that's going into the duodenum, and then that's probably a pancreatic duct. Okay, thank you.
All right, so that's showing.
I'm confident that I can put a clip on that.
So again, he's put in this cannula and injected dye. And this, what he's trying to make sure is when he clips it, he's not clipping the hepatic duct, he's clipping the cystic duct. So he's not going to block liver outflow of bile. Let's see if I can scoot past. Okay, good. So this is a super quick memory of short-term memory. What structure should be ligated to remove the gallbladder? So remember, he's got that cannula in here and he's looking at these bile ducts. Is he going to take out the cystic duct, the common hepatic duct, or the common bile duct? And I'm hoping you're going to say the cystic duct, and the little circle went around the wrong answer. But the right answer is you want to take out the cystic duct. So this duct is what you want to remove along with the gallbladder, because the liver is going to continue to produce bile, and that bile is going to come down the common bile duct into the duodenum. Okay, so let's go into the small bowel, colon, peritoneum, and mesentery. This is kind of confusing, so I'm going to go through it very carefully. First of all, to remember the name of all these segments of bowel, you can remember Dow Jones Industrial Average Closing Stock Report. Duodenum, the first part of the small bowel coming off the stomach. The jejunum. Then the ileum is the last segment of the small bowel that connects with the cecum, or the large bowel. And the ascending colon, transverse colon, descending colon, and the sigmoid has this S-shaped curve. That's what the S is for. And then, of course, the rectum. And the very end is the anus. Oh, I forgot. Here's the appendix. So that comes after average, or as average. All right, so the supporting structures for all this intestinal system are the peritoneum and the mesentery, the organizers. The peritoneum contains the bowel, predominantly the small loops of bowel. And the mesentery keeps everything from getting knotted and tangled. So the peritoneum surrounds a lot of different structures. There's a parietal peritoneum covering the lungs. Of course, there's the heart has its own covering, pericardial covering, and they all of them secrete this lubricating fluid. So it keeps everything lubricated, moving around so nothing gets stuck. The mesentery is a fold of that peritoneum, and it keeps the bowel from getting knotted. And here's a good sagittal view looking at the peritoneum and the mesentery. So the peritoneum for the abdomen, this peritoneum covers like the sac, the outside of that balloon sac. And it's enclosing certain organs of the abdomen, but not all. Some other organs it doesn't cover, like the transverse colon, the kidneys. And then there are folds of peritoneum, and these folds of peritoneum, they're shown here in purple, is called the mesentery. So it keeps this mess of bowel from going into all these tangles. The intraperitoneal organs include the liver, the stomach, the spleen, a bulb of the bulb or the first portion of the duodenum, the jejunum, the ileum, parts of the colon, the uterus. And then the retroperitoneal, things that are behind the peritoneum, would include the pancreas, kidneys, descending colon, and the subperitoneal, beneath the peritoneum, bladder, prostate. Okay, so let's go on to the colon now. I want you to look at the segments of the colon. There's the beginning, the cecum, transverse colon, descending colon, sigmoid colon, and rectum. Notice where the feces tend to sit for a while. Remember, feces are things you're going to get rid of. They're not only waste, but they're potentially full of toxins. So, question, feces contain this toxic waste. Where is colon cancer most likely to develop in the bowel? In the cecum, rectum, sigmoid colon, or all? I've given you a hint because I've made those colors in brown. So the answer is all of the above. So colon cancer, colonoscopy is recommended about every 10 years after the age of 50. And the highest cancer rate are in those countries with low fiber and highly processed foods. So they're going to be more toxins. So notice these are the areas of the bowel that are highest in cancer rates. All right, next question. Let's go on a little bit more of the bowel. This is showing a segment of the sigmoid colon. Which is worse, osis or itis? Diverticulitis or diverticulosis, or are they both the same? So I hope you're answering diverticulitis. This is inflammation, then it develops infection, bleeding, and potentially these can perforate and cause peritonitis. So this can extend on into the peritoneal cavity. So diverticular disease includes all of it, caused by low fiber diet, chronic constipation. So the treatment for the itis is antibiotics. And then when things cool down, they could do a bowel resection. Now, osis, diverticulosis, are these small balloon-like projections. And prevention and treatment is a high fiber diet. So in summary, we've gone through the pancreas, gallbladder, how it could potentially cause these gallstones, how you can live without your gallbladder and still produce bile. And we've gone through the colon, the peritoneum, and the mesentery. And this is from the anatomage table. It's showing a video of the pancreas and some of the bowel. So it's sweeping around. We're looking now on the posterior side of the body. Pancreas here, and of course, the gallbladder, and then look at these bile ducts. And now we're down to just the pancreas and showing that pancreatic ductwork. Now the body's coming back. Okay, any questions, comments, please leave in my section and subscribe to the channel. Thank you.